in just showing you some of the links, um, just for the people who have not been. Yeah, you can see the screen. Just a second. Can you please mute yourself? I request all of you to mute yourself. Okay. So this is the, because some people don't know about it. Actually, I have done its monetization, but I have no aim to become a billionaire from this YouTube. Okay. This is my just in my mind that if I get something, I will use it for something good. Okay. Because at the moment it's not been monetized. So there is some step which is missing. You see, action required, complete your, and I'm not able to do it. What is it? So first of all, because people sometimes think that when I am pushing them, they think that it is for my personal or financial benefit, because at the moment I am paying for the subscription which I have taken for the articles, this folder which I share with all of you. Okay. So just, this is not to impress you. It is just to show you that I am doing this, all this stuff for you people. Okay. And if you want to find something, okay, so these are playlists. So all the discussions, because before I used to do it in our native language, so later on I developed in English. So majority of the lectures regarding like in late, maybe last 1 year almost, it's in English. So it's like these, and then these are few of the playlists which I have made. And this is some like religious teaching which I have started, but it is exclusively for the people who are interested. Okay. And you will find all the playlists here. So this is just few minutes to just let you know that whatever discussions we have done, it's all available here. So you just need few minutes to see where are different things, and then you can, and any question if you have from any of the discussion, you can just share me the link with the minute of the discussion, that at which minute you don't understand anything. So I will reply to you. Okay. So today, in last few discussions, I have just started a quick review about anesthesia evaluation and anesthesia, like how to proceed with the, because whenever we get information, we have a cardiac patient, or we have a patient with respiratory disease, or we have a patient. So today we have covered cardiac patient, we have covered respiratory disease patient, and we have covered liver disease patient. Okay. So today we will just have a dissection of renal disease patient. Okay. So if anyone can volunteer, what will be the symptoms, signs, findings you will get in a patient in which there is some renal disease? First of all, it may be acute renal failure, which will be associated with some intriguing factor, whether it is pre-renal, okay, or renal, or post-renal, okay, or it will be CRF because of hypertension, because of diabetes mellitus, because of some glomerulonephritis, some autoimmune disease, or whatever like that, or as a result of CLD. Okay. So like a picture will be somewhat like that. And then what will be the symptoms which you can have commonly? Okay. So anyone, please, what can be the symptoms in renal failure? Yes, Shemail. Anyone wants to volunteer?
I think, sir, can I participate?
Yes, sure. You are the boss. Yes.
No. I think that the renal patients, they most of the patient, they have other comorbids. Most of the time they are hypertensive, diabetic, or any other comorbids. First of all, second thing, before was like now the old patient, but now there's also the range of age coming down. In the early age also there is, you can find the renal patient.
Mm-hmm.
And when they come to the anesthesia, most of the time they come for other than renal surgery. And definitely they come at stage of when they are at very advanced stage, or might be they have hemodialysis or an other treatment to wash out their creatinine and urea creatinine. And
Mm-hmm.
we found these patients most of the time, first I told they hypertensive, anemic due to might be, first of all, definitely there is no erythropoietin production in the kidneys. And second, also due to hemolysis, due to the high level of creatinine and urea.
Mm-hmm.
And sometimes the patient, definitely they are, if on hemodialysis, then they have multiple, at least 3 times a week they go for hemodialysis. And
Mm-hmm.
definitely in that procedure they lose their erythrocytes also. And ultimately they are anemic.
Mm-hmm.
And the third one, definitely the patient sometimes have also ischemic heart disease due to the high level of urea creatinine. And they have pericarditis. And what we can say, to find these patients, uh, depressed patient also, they are definitely at that stage when they have the chronic disease. They also some have psychotic means problems, or they are maybe depressed. And
So actually, if I
these patients,
just summarize what you are saying, that usually there will be primarily symptoms of the disease process or the preceding event which lead to either acute renal failure or chronic renal failure. Okay. So acute renal failure
yes,
usually will be related to hypovolemia or crush injury. Okay. Or some acute renal toxic drug like for example, any anaphylactic reaction or anything which is doing AKI, acute kidney injury. This there are certain medications, antibiotics, contrast, which can cause acute renal failure. Okay, so this will be one group of patients. The other group of patients will be who are having like hypovolemia, this bleeding, and which is leading to hypoperfusion and leading to acute kidney injury. Okay, so or there will be some patients who intraoperatively are having hypotensive anesthesia or having like for example these patients like having this aortic surgery in which there is clamping, cross clamping. So that will be one category. Okay, but usually whatever is the cause is, usually the things will be like related to anemia. Okay, related to primary disease, things related to dialysis. Okay, patient may be uremic. Okay, patient may have some problems related to like because potassium is not being excreted, so things related to hyperkalemia. Okay, then there are some symptoms of regurg because of gastroparesis. Okay, then because of these if I'm not wrong, if it is related to, for example, renal failure is also combined because of a result of hepatorenal syndrome, so all symptoms related to liver can be there. Okay, and then generally symptoms are related to overloaded circulation, like there may be craps, there may be edema. Okay, edema near the eyes, periorbital edema or peripheral edema. Okay, so things will be generalized. Okay, so the shortness of breath can be there. The generalized symptoms which can be there in any other disease like respiratory or cardiovascular system can be there. Okay, so if we just focus separately, what will be the sign symptoms of anemia? Shimail, Fatima, if you can tell. Sign and symptoms related to this one, anemia. Or Sagar, whatever, whosoever want to tell. Yes, Shimail, you want to tell?
Yes, sir. There will be shortness of breath and fatigue.
Okay, shortness of breath, fatigue, tachycardia,
tachycardia, and
pallor.
pallor on examination, pallor, and
Okay.
then on investigation.
Like sign symptoms, focus on at the moment, only focus on sign symptoms. Okay. Or if, because usually this is in renal failure, there will be generalized sign symptoms, but in with reference to renal failure, it may be multifactorial because of bleeding, because of erythropoietin. Okay. There is also anemia of chronic disease, chronic illness. Okay. So there are a number of factors which are leading to anemia. So you can dissect it and you can go further. What are the problems related to dialysis? Like what sign symptom will be there because of dialysis?
Sir, we can categorize into two subtypes, like classified. First, it's a
Like,
complication related to the catheter, and second, the complication related to the procedure by itself, the dialysis.
and even procedure, and also because of the things which are being used, like anticoagulants. Okay. So you can have problems related to electrolytes. Okay. So you just have to evaluate the blood levels as well as clinical. So patient might have this dyspnea. Sorry, dyspnea, not what do you say? Syncope. Okay. Because of electrolyte imbalance, what is called as disequilibrium syndrome. Okay. So this can be there. Line related problems will be related to infection, local swelling, or for example, not only line related, fistula. There is one thing is line and one is fistula. Okay. So fistula related things will be there. So you have to evaluate. And of course, when the patient is dialysis dependent, you have to make sure the dialysis is adequate and it's being done before procedure within certain specific period of time, like within last 24 hours, so that you have better platelet function, you are having better circulatory effects, better electrolyte balance. So this will be important for the conduct of your anesthesia. So whenever you are having a patient with on dialysis, you have to make sure about things about like that. Okay. So also things like infections will be there. Actually, we are just having a quick review. So I'm just touching each and everything, and then you can go in details or we can discuss, because whenever you will have a patient in your long case, or in if they are asking you even in table viva, if you have the approach that a renal failure patient will have these things to be considered, so it will be easier for you, that you will not miss anything. Okay. So this is, and then another thing is that if this reason was glomerulonephritis, so patient might be on steroids. Okay. And might be on immunosuppressants. So that should also be your consideration. So what else? Okay, so a few words about some investigations. So usually how you evaluate, like we see urea, we see creatinine, we see serum electrolytes. What we see in CBC?
CBC.
Ultrasound.
First we do the CBC, yes.
What will be the findings in CBC? Anemia?
Anemia, we can find the erase of WBC in case of there is an infection. So that these patients are prone to peritonitis or some other disease.
Platelet function will definitely be reduced, but what about platelet number?
Sometimes if the patient is on heparin, we can find also from.
But platelet number may be normal. Okay, platelet
may be normal, yeah.
But platelet function will be a problem. So also coagulation coagulation profile. Okay, like coagulation and bleeding profile, I would label it. So this PT INR, will it be disturbed or no? APTT.
I think if patient have a good liver function, it will be normal. But BT can be prolonged due to the defective platelets.
Actually, APTT or even INR can raise, because heparin, usually we know that it is affecting APTT. But if it is a patient is having residual, it can affect both of them. Okay, because these all coagulation pathways are interlinked. Yes, of course, APTT may be raised because of residual effect of heparin. Okay, and clotting time, bleeding time will be increased because of platelet dysfunction. Okay, and if you want to see exactly the platelet function, you can have platelet function assay, in which they see the platelet function. Okay, so urea creatinine, and they do 24-hour urine, and yes, urine RE routine examination as well as culture. Okay, in ultrasound, usually they see the cortico-medullary differentiation. Okay, because by that they label how much renal function has been deteriorated. Also, not only by this differentiation, and also with the creatinine clearance. Okay, because there is one classification of CRF according to GFR. I don't remember the number, but usually it is 120, and if it is less than 10 ml something,
120 to 90, it's first stage, but there is
less than
no
10 is
clinically,
anuria. Yeah, anuria.
from
And in
90 to
between there is
60, it's
mild.
great.
Yes, and there are, you can see in the book, you can find it. So you will be classifying the CRF according to the GFR you are getting. Okay, and creatinine clearance. So that's how you will be evaluating a patient. Electrolytes will be disturbed, like potassium, okay, sodium, calcium. So all these, there may be hyperphosphatemia. Okay, so these all will be in your consideration when you are evaluating a patient. And of course, the secondary problems, like for example, if patient is diabetic, you will be looking at the diabetes control. If the patient is hypertensive or have any signs of failure, you will have ECG. Okay, if the patient is having signs of overload, you will have chest X-ray. So you will, like, these will be associated investigation. And if patient has other risk factors, you will also do echo. Okay, so like this will be like any routine echo examination with reference to systolic, diastolic, valvular, chamber, clot, and pulmonary hypertension. This is just a summary of echo. And with reference to chest X-ray, you will be finding any like signs of failure, and increased bronchovascular marking, development of pneumonias, pleural effusions. Okay, so that will be it. And ECG, any finding, any arrhythmia can occur. There may be some blocks, there may be arrhythmias, there may be ischemic signs. So anything, because it's in an open for discussion. So anything can occur, but you will be evaluating logically. Okay, so you will be looking at the primary pathology, what the primary pathology the patient has. Okay, and then whether it is ARF or CRF or ARF on CRF. Okay, because if it is, for example, ARF, you might consider myoglobinuria and things like that. Like in trauma patient, you will consider. If the patient is in hyperperfusion, usually it will be reversible. And for acute, there is this rifle criteria. Okay, you can, or ACAN. There are two criteria by which, according to GFR, according to creatinine, and according to duration of this, they categorize either it is risk, injury, failure, loss, or end stage. Okay, so this is rifle criteria. So in acute setting, At the end of the day, you will be looking at in this way, rifle, okay, or akin. Akin is also similar. I don't remember what, but the basic thing is the same. How much creatinine is increased, how much GFR is reduced, and how much duration has been gone. Okay. So this will be for acute, and there will be any signs related to that disease or any signs specific because of overload. There may be palpitation, arrhythmias will be presented as palpitation, anemia, or acute decompensation will be apparent as shortness of breath. Okay, loss of consciousness or decreased level of consciousness will be in the form of uremia, flapping tremors, signs of anemia. Okay, so this is just, you have to think logically and you will be evaluating in that way, and then you will have some investigation, or on the basis of those investigation you will be labeling the patient. Okay, so in last 4 discussions which we have done, if you can just see that whenever we have a patient, now what happens that in our practical conduct of anesthesia, you will not have a patient with only renal problem, or you will not have a patient with only cardiac problem. So actually you will be correlating. So generally symptoms you will find in any patient related to cardiovascular and cardiorespiratory symptoms, and then you will find any other symptom, and then you will be correlating. You will try to find the risk factors, and then you will be conducting the anesthesia accordingly. Okay, so we actually, if I will highly suggest you to listen to our previous 3-4 discussions. You will get a very good concept of how you should be anticipating when you find this news. So as we did for other systems, similar we will do here, that if you have a patient, like if the patient is on coming for any procedure, like it may be the procedures which maybe there are related to, for example, dialysis, or dialysis like creation of fistula. This is one sort of procedure. Or for example, maybe these patients have some obstructive uropathy. So these patients can have surgeries like that, like you might have a patient for URS with CRF. Okay, you might have a patient with bladder problems developing CRF. Okay, similarly this TURP. So you will be having just like any other patient, you will have patient related concerns, surgery related concerns, okay, and anesthesia related concerns. So you will be anticipating in that way. So, but usually if you have a patient, you will be avoiding like there will be risk of aspiration. So you can have because of gastroparesis, you will have risk of arrhythmias, okay, because of electrolyte imbalance. You can have exaggerated like not only hypertensive response, but also hypotension or collapse at induction. So you might be anticipating that thing. So usually intra-arterial blood pressure monitoring is a challenging thing, because you avoid upper limbs, because these usually are site either the patient already have fistula, or that patient needs a potential place where we should try not to cannulate for arteries or even veins unless you are not. It is preferable to take it in the lower limbs or central line if possible. If you are like, you should not try to waste, because that place may be site for fistula. Okay, so that will be one thing. And so usually it is said that if you want to have arterial blood pressure monitoring, I have never done in my life, but they claim in the books you will find dorsalis pedis artery for intra-arterial blood pressure monitoring. Okay, because you might have this problem. Then among the muscle relaxants, succinylcholine will be a tricky thing because it can cause hyperkalemia. So you will try to avoid it. In the places where we have rocuronium, actually nobody is using, okay, succinylcholine. I have not used even maybe 1 or 2 times. I think even not 1 or 2 times in last 11 years. I have divorced this medication. I have never used it since I left Saudi Arabia, left Pakistan. But muscle relaxant, which is good for maintenance, is cisatracurium, okay, because it has least dependent. Even atracurium is good, but cis-atracurium is the bad because it will not even release histamine. So it's a mesquine muscle relaxant. So it is the best. You will not use pancuronium or vicuronium. Even rocuronium, the problem is that it also has renal excretion, but it has both renal excretion and as well as liver excretion. So you can use it if you have Sugammadex, okay, or you will reduce the maintenance dose, okay. You will reduce the muscle and you will do the neuromuscular monitoring, okay. Neuromuscular monitoring you will be doing, okay. So this will be related to like other steps like induction agent. You can use anyone, propofol. You can use, if patient is hemodynamically unstable, you can use ketamine or etomidate if you have some cardiac involvement. Like there is no hard and fast rule, there is no pick and choose for it. Hypantone you can also use, but again, related to the hemodynamic instability which can have, okay. Among the opioids, okay, among the opioids, morphine, not at all, because it has active metabolites. Pethidine, tramadol, like pethidine can also has an active metabolite, which is norpethidine, okay. So actually pethidine is not a very good opioid. People are using it, but I don't know. Tramadol with reduced dose you can give, but better will be remifentanil, again for the reason that it does not require kidneys for excretion. Fentanyl in low doses have no problem, but again remember that if you are using fentanyl for a long time, its elimination half-life is as long as morphine, okay. So remember this thing, okay. So don't think that fentanyl is totally safe. If you are using fentanyl for a long time, for example in ICU, you will have a lot of problem if the patient has disturbed renal function, okay. Similarly, like benzodiazepine, diazepam and midazolam, even if you are using for pre-medication, should be used cautiously because both of them have renal excretion. So this thing should be in your consideration, okay. This neostigmine also renal excretion, so you have to reduce the dose if I'm not wrong, because this again I tell you that with the use of Sugammadex, I'm forgetting these medications actually because whenever Sugammadex is available, I never use it, okay. So what else? What about fluid? I'm sorry, I don't know what is happening. This is not in my control. Okay, fluids, normal saline is generally not normal, it is always abnormal. So similarly, if the patient is having signs of acidosis, normal saline will not be a good choice, okay. So actually plasma light will be a better choice, plasma light, because it will have a balanced solution. Ringer lactate, again, the problem will be related to potassium, even hair potassium. But if the patient is not in failure, you can use it according to the situation. If the patient is on dialysis, if you need, or it will be better overall to use colloids. Okay, if you want to just give some volume, it is better because very little volume you can use for the maintenance, for the maintenance of the intravascular volume. So colloid will be a better choice as compared to, like for example, if you have this albumin 5%. Okay, so this will be a good choice. I don't know what is happening. This one. Okay, so blood transfusion, actually patient will be compensated. So even they have high transfusion triggers. You don't, usually it is said that you have to maintain more than 10 gram per DL for cardiac patient, but usually these patients are well tolerated even at 7 to 8 gram per DL. Okay, so you just have to individualize. There is no a single word transfusion trigger in these patients. You will assess the situation, and if you think if it is required, you can give. Okay. So what else? Monitoring, invasive monitoring you may need, usually CVP or things like that. Because if the patient's urine output, if patient is not on end stage renal disease, you still have to pass the Foley's and you still have to monitor the urine output, because you can add some of the volume with of the fluid which you are giving, because not every CRF patient will be of the same category. Patient is passing urine or patient is not passing urine, patient is in overload or not overload, because you have to maintain the intravascular volume anyways. So you still need to give some fluid. So that's why it is always tricky to give. You can aid your manage fluid according to ABGs. If the electrolytes are normal, then you can still give ringer lactate or plasma light. Okay. Normal saline you also give, as I told you, that it is only related to high chloride and chances of more acidosis, because these patients already have chances of metabolic acidosis. Okay, because of not excretion, high NN-VEP, metabolic acidosis. Okay, so what else? Anything else? Anything which I missed? Any comments? Jamil, would you like to add something?
We can use dextrose half saline. And as you already told, sir, that depends upon the severity of the disease. We can take consultation from the nephrology people.
Yes.
If patient is on dialysis, then they will adjust the fluid take. Sometimes,
because actually, post dialysis, Jamil, as you know, that post dialysis, sometimes these patients are hypovolemic.
Yes, need hypovolemic. Yes, definitely.
Yes, so you might need fluids. So in that scenario, there is not a single word answer actually. You just have to identify the patient's condition and anticipate accordingly. Okay. So
yes, preoperatively you can take consultation from nephrology, but definitely interpretively nephrology will be not around. But you have the one who assess the vitals by if there is urine output, or if not urine output, then you will assess how much the blood loss.
Anesthetist is like Janine. We are not human beings. We are jinn. We can even, yes, some days ago, there was a fight with me by a orthopedic surgeon because he was asking me to pass Foley's. Okay. So I said, I will leave medical science if passing Foley's is the responsibility for anesthetist. Okay. So the thing is that in perioperative period, anesthetist is doing everything. Okay. We are nephrologists, we are cardiologists, we are even sometime maybe, actually as we are helping the gynecologist as well to bring out the baby. There is a lot of calories which we burn when we are asked to have the fundal pressure. And gynecologists, sometimes they are not able to deliver the baby without the fundal pressure of the heavyweight anesthetist. Okay.
So, and also sometimes the moral support also we giving.
Moral support also. Okay. Otherwise, anyways, there are a lot of women here at the moment, so they may be angry. But other than Pakistan, you will find a lot of male gynecologists. Though I still say that if even if you are working only in maternity hospital, so after some time you feel that your gender is just like this consideration of transgender going on in Pakistan at the moment. So I when I worked for 3 months stat in the maternity hospital, after that I was feeling that have some change sensation in myself. So actually this has a big effect, but anesthetist has to tackle all the situation. Believe me, the care of anesthetist is just like care provided by the mother. Okay. So I am proud of being an anesthetist, and I want you to be like that. For that, you need to improve your knowledge. And for that knowledge, you have to make your concept. Remember, if you have good concept, the exam will be at the tip of your shoes. So don't worry about exams. People around you discourage you, depress you. Oh, this is a dead specialty, etc., etc. But I tell you something, there is no other specialty which is even comparable to anesthesia. You should be proud of yourself being an anesthetist. Of course, the social situations, the respect, we don't get respect as we should. But remember, I love myself being an anesthetist, Because remember, anesthesia has very little knowledge of anesthesia. It has everything other than anesthesia. Okay. So that's why if you are only trying to find out the best patient care or best exam preparation from one book, you will be in disaster, because you need to open up your eyes and ears and search here and there to have the better and better concept. Okay. So we will discuss in similar fashion. I will have 2 or 3 sessions, one on elderly patient, one on pediatric patient, one on gynecological patient, and then few sessions like that. And then we will go back, because I was thinking that some of the people who are going for Viva will be benefit. It's very nice that I don't find anyone who is for Viva. At the moment, is there any Viva candidate around? Okay. So any questions before we finish? I hope you understand some of the concept. Open the book and you go in a little bit of details. But remember that whatever monitoring you are doing, whatever question you are asking to the patient, you should have a rationale. You will not be asking any question or looking at any investigation without a reason. There will be reason for any investigation. Even some of the investigation, I think I have missed about what one of them will be albumin, because there is hypoalbuminemia even in renal failure because of loss. Okay. So like whatever investigations you are looking at, you should know the reason, and you should know what will you be doing for that change investigation. Okay. So I hope you like this way, and any questions, you are welcome anytime. Okay. So I will finish here if nobody. Thanks, Jamil, for joining. Anyone who has passed the exam and is coming,
thank you.
I'm really thankful. Okay. So
Most welcome, sir.
Okay. Anyways, thanks a lot, everyone. Bye-bye.